The pre-transplant journey starts with the diagnosis, and for parents, it's a very different experience depending on what the diagnosis of the child is, when you found out that your child needs a liver transplant, and how long can you expect your child to remain stable on a waiting list. These are all very different factors that affect the mentality of the parents as they go forward. There is a lot of stuff now on the internet, on sites like the one we're on today, where parents are able to share information, and you didn't have to learn about your stuff about the green baby boom from the journals that were available at the checkout counter in the past. Next slide, please. The pre-transplant expectations are somewhat dependent on the acuity of the illness of the child. There's a scoring system that was devised, quite a few years ago, the PELD score, which many of you may be familiar with, which is based on the acuity of the illness in patients with biliary atresia. But it has many limitations. And depending on the illness of the child, you may have a low PELD score or a high PELD score, or you can have what's called a status 1A, which is the highest acuity, or a status 1B, which is a class of acuity reserved particularly for children who have chronic liver disease with a sort of a sudden decompensation. I think it is pretty common understanding among all of us who deal with pediatric liver disease that these exception scores do not always accurately reflect the mortality of the child within the first 7 days or the first 3 months, which is what the scoring system was devised to do. So most of the children nowadays are actually transplanted with exception scores. And it's the job of the National Review Committee to look at these exception scores as appeals by program who are trying to get more points for their patients. And the bottom line is that there just aren't enough livers to go around and meet the demands of these sick children. The PELD score does not, even though many patients are transplanted with exception scores, all patients with liver tumors and metabolic conditions are transplanted with exception scores because these patients do not commonly have liver disease. They have urgent indications for transplant based on other things. So you can see on the left, there's a baby who's kind of waiting at home. He's in a clinic, and there's a baby in the ICU. So the expectations and the anxiety level for the parents of these children can be quite different. Next slide, please. So the transplant evaluation is really where the rubber meets the road. It's when the team has somehow decided that it's time to evaluate the child formally for a transplant. And this can be the day before a child is listed in the case of acute fulminant disease, or it can be months before the child really needs to be transplanted badly if a kid has something like a chronic liver disease such as biliary atresia, where the discussions may have taken place shortly after the Kasai operation. So the evaluation is the opportunity for the parents to meet everybody on the team. The hepatologists usually know the patient already, but the family gets to meet the coordinators who will be incredibly important in the future of the relationship between the team and the child and the parents. Pharmacists and of course social workers, incredibly important in trying to sort out the many different needs that these families have. The financial specialists, which are unfortunately a necessary thing these days with all of the myriad complications with regarding financial problems. And finally, you get to meet the surgeons. Now, the surgeons are not always familiar with the family because they may have been introduced to the family pretty late in the process. So it's very important that the family gets to have all of their questions answered. Next little animation, please. So ask questions. That is the message that I would have for any family who's going to be going through a transplant evaluation. It doesn't matter how small the point is or how many times you may have asked a question. It's pretty well known that people only retain about 15 to 20% of what they're told at any one given time, and that about a week or two later, they've forgotten much of what they've been told. So we encourage people to keep coming back to us with more questions, through email, through my chart and other uh, media, because the concepts that we talk about are very complicated. It's what you expect at the time of the transplant. What are the complications that are going to be happening after the transplant? And very importantly, there's the whole discussion about living donor. You know, we introduce it in a way that doesn't sound like we're obligating the family that they have to have a living donor, but we try and encourage them by telling them about the positive aspects of living donor donation. Next slide, please. So this is the hardest time for the parents, is when they're listed. The stress level must be incredibly high. I think they can't possibly conceive of anything that's really more stressful. Next bullet point, please. I think there are limits on lifestyle, depending on, next slide, please, whether you're in the ICU. But even if you're waiting at home, it's really hard to go on vacation. It's really hard to do, to have a normal life. And I think one of the interesting things that parents express to me is they have guilt about waiting for a donor, because as much as they want their child transplanted, unless they have a living donor, they know that someone is going to have to die in order for their child to get a liver. And I think some parents, not all, are racked with this kind of guilt about wanting to have something happen quickly for the child, but realizing that something bad has to happen to some other child. And of course, after the transplant, or even before the transplant, parents want to express their gratitude to the donor family. The time for preparation for all this can be very contracted in the case of a sick baby or someone who comes in with chronic liver disease, or it can be a long time if someone has a stable metabolic condition. So that the time frame that this process goes through can be very, very different among families. Next slide, please. Okay, so the problem is, of course, organ supply. There's a shortage of donors. There's a size incompatibility because most of the kids who need a transplant are infants or young children, whereas most of the donors are generally adults. Next slide, please. My little yellow baby friend. So here is a pie chart, which I like. Pie charts are very easy to understand, of a age distribution of recipients that done at Lurie Children's Hospital in the last 10 years. So you can see the majority of them are in the blue or the red slices, which is almost 60% of our patients are kids below the age of 5. Now, if you look on the chart at the right, you can see that the peak number of donors is in the ages 15 to 34. So when I first started doing liver transplants, we had a very, very high rate of mortality on the waiting list because you were always waiting for a donor that never came. Somewhere in the late 80s, early 90s, we started doing reduced size transplants and split transplants, which I'll talk about in a few minutes. And that was a huge improvement in our ability to meet the needs of the sick babies on the list. Next slide. So the technical variant transplants, I'm not going to show a lot of OR pictures, but this one is kind of, I think, a necessary thing. When we get a liver from an older donor, we have to cut it down the middle or sort of off to the side to match the size of the baby. And the great thing about these technical variant transplants in this age when donors are in short supply is that you can actually get 2 patients transplanted with 1 liver. Next, and you can see here a very happy picture of 2 of our children who were transplanted with a single liver. Now, this doesn't happen very often because it takes a tremendous effort on the part of a team to do 2 transplants at once, but it happens on occasion. But the great thing about it is that the part of the liver that we don't use goes to an adult who's on the transplant waiting list. And so the more technical variant transplants that are done in this country, the better the situation will be for people who are waiting on the list, who are obviously very desperate to get a liver. Next slide, please. If you look at the frequency of split liver transplants between the 20 years between 1991 and 2010, you can see that there very few were done in the 90s and early part of the 21st century. In blue is when we started doing split liver transplants around the year 2000. And you can see that even though this slide is 10 years old, it's current in the sense that about 50% of our transplants now are done with organs that are obtained from adults who are then split into two sections, one for a baby and one for an older child or an adult. Unfortunately, this practice has not really taken off as well as we might have wanted. The number of split liver transplants in this country, next slide please, you can see has remained somewhat static. The great majority of children in this country are still transplanted with whole livers, and even though there's been a modest increase as exemplified by the brown line, we are still at the 20% mark. And there's no obligation to split livers. It's really completely on the center itself, whether they want to engage in this kind of practice. And the more people who engage in this kind of practice, the better it will be. Next slide, please. One of the interesting things about living donors is that we all, the first living donor transplant happened in Australia many years ago. In this country, it happened in the University of Chicago in the 90s. And it's become a basically staple of most pediatric liver transplant centers to offer this service, where a child, parents usually, or a relative are the donors that will usually donate about 20% of their liver mass to the child. Now, what's interesting, and this is data that is very, very recent, you can see that there's kind of a drop-off in the frequency of related living donors. I can't explain that. But what's remarkable is to see the uptick in the green line, which represents non-directed altruistic donors. So a lot of people are stepping forward and saying, I want to donate a part of my liver to a child or to an adult, but often it's a child. And this has become an important source of organs, particularly for children. And there are a lot of ethical discussions about how we allocate this resource, because in a non-directed donation, do we follow the list, or do we make up our own minds about who that patient might be? There are no allocation rules at the moment, but it's something that I think we all are very interested in seeing how this evolves. Next slide, please. The transplant phase, of course, is where the parents sit in a waiting room or somewhere and they pray or keep their fingers crossed and wait for the surgeon to come out and tell them how things have gone. What influences the length of the surgery is, has there been any previous surgery? What's the size of the child? What kind of graft are we using? Next slide, please. The postoperative phase is really characterized by a variable length of days in the ICU. You can expect your baby to be on a ventilator. You can expect imaging that happens almost on a daily basis. The first post-op day is the day that I think everyone wants to see that post-op day ultrasound. On the right, you can see a nice hepatic artery signal, a nice portal vein signal. Unfortunately, we prepare our families for returns to the OR. It's not always a bad thing. Rounds can be somewhat confusing for parents because now we have family-centered rounds where the parents are really an active participant in the rounds. And we have to be careful when we discuss things, and there might be some disagreement about some point of care where that the families don't perceive this as the team actually strongly disagreeing with each other. Some families object to this. So now we have actually taken to sort of have the real rounds sort of in private, and then when we have a consensus, engage the family to tell them what we think the right thing to do would be. But it still can be confusing for families because there are so many caregivers and they hear so many different things from so many different people. Next slide, please. So the roller coaster analogy or metaphor has been used many times to talk about what it's like to be in the ICU with your child who just had a liver transplant. You have a euphoria of having finally received the liver, but every day seems to have its ups and downs. Will the liver function properly? What's the risk of bleeding? One of the focuses of our Starzl network right now is on the anticoagulation practices of our centers. Almost every child is on a blood thinner of some kind, and those blood thinners are used extensively to keep clots from forming in the arteries and portal veins to the liver. And as a consequence, there's an increased amount of bleeding, which worries parents a great deal. Sorry about that. That's the announcement. Anyways, about 30% of all patients have to return to the operating room within the transplant admission. Next slide, please. Fortunately, the liver has an immunologically privileged position among the organ hierarchies. The incidence of rejection is anywhere between 15 and 20% in that first year. Sorry about that. But the good news is that rejection is not usually a serious problem within the first year. It can be easily reversed. Next slide, please. The good news is that patient survival is great no matter what your age group. You can see here a 5-year survival curve is in the order of 90% for all children, whether or not they're less than 1 year old or whether they're teenagers. Next slide, please. There seems to be a small survival advantage for living donors in comparison to deceased donors. Even though living donors can be technically challenging for the families, for the team, they do seem to have a better overall result. Next slide, please. So the long-term survival is good. I want to just show a couple. Here's my famous yellow baby picture, and I'm going to show you the kid 20 years later. So this was at the Toronto Zoo on the 20th anniversary of the Toronto Transplant program that I started a long time ago. And Vicky Ng, who's there right now, decided to have a party, and she invited all my old patients. And so this kid was like, "So you're the guy who cut my liver open?" I'm like, but you know, it's so gratifying to see these children. And I think as parents, you have to understand that even though you've gone through this incredibly intense experience in your child's life at an early stage, these kids can have a wonderful, happy life. Next slide, please. This baby was transplanted on Mother's Day, 1987. It was one of my first liver transplants. He had biliary atresia. And next slide, I met him at the zoo, and I thought that he was his father. I saw this guy coming towards me with sunglasses, and I said, "Oh, Mr. Raposa." And Mr. Raposa was a little old guy next to him, and the boy was actually got married a few months later. And so that was an incredibly gratifying experience too. So I think as parents, next slide, please, you have to understand that no matter what you go through, the transplant outcomes are excellent and your children have a wonderful life ahead of them in most cases. I always wonder what babies who have their transplants figure out later on in life. And this was a drawing that was done by a girl when she was about 11 years old who had been transplanted as a baby for biliary atresia. So, you know, it's always wonderful to understand, trying to understand what these kids think. So she drew this picture. She's kind of the circle girl at the bottom, and she's got a liver coming out of her head. So the liver is anatomically really good, but of course it's coming out of her head, which may indicate the importance to which she gives this organ. But what's really cool is that I am above her with protective arms around her. And I was incredibly moved by this little girl giving me this picture. It's in my office right now. And her perception of her journey through the transplant. And I think it's going to be very important in the future, now that children are surviving, to understand how they survive and what their long-term problems are. As a last message, I want you to choose your liver transplant center wisely if you have a choice. Not all centers are equal. I'll leave it at that. Anyways, that's it. Thank you for listening, and look forward to the rest of the talks.